Έχουμε τη χαρά να έχουμε μαζί μας έναν από τους σημαντικότερους ερευνητές στα θέματα της επεμβατικής πνευμονολογίας στην Ευρώπη, τον κύριο Ροσέλ, ο οποίος έχει έρθει από την Ισπανία. Θα μας μιλήσει για τα stent στους αεραγωγούς και για τις εξελίξεις στα ειδικά stent που φτιάχνονται. Είναι ένας άνθρωπος ο οποίος κάνει όχι μόνο κλινική αλλά και βασική έρευνα. And I would say, welcome, Professor Rossel. It's a very big joy for us to have you with us today. Tony Rossel is a good friend of us and has come many times in Greece in different opportunities. So we're very glad to have him tonight to talk on the novelties on stent, on airway stents, and the procedure of placement, but also the search for the ideal stent. So, dear Tony,
okay.
Please.
Thank you, Grigoris. Dear colleagues, good afternoon to you all. I would like to thank the organizing committee and the society for inviting me. It's a pleasure and an honor to share my thoughts and my experience here and now. So, when you find this, you can see on your left, it's a benign scarring, and on your right is a tumor. When you have this, you know that there are few possibilities to have surgery, and you know that treatments are not very good. So you probably need to go to endoscopy and have some laser ablation, maybe dilatation and stenting. If you solve this, you know that you're going to have a benefit on survival, and it was confirmed many years ago when you were testing laser against radiotherapy, and those patients that went with laser went very well, and you see they double the time of living. 15 years after, you see that for those patients that you can solve the main obstruction, the main airway obstruction, live the same that those without obstruction. So you can really make them the same group. And very recently, a paper from Dr. Gratacos that confirmed that if you don't treat the main airway obstruction, your patients live less. As a matter of fact, they live 50% less. So there's a big impact on survival. More or less, you can gain 50% more of time. But not only on survival, but also on quality of life. This is a paper from the 80s. You can see that it's about Karnofsky index and dyspnea. You can have a better results on survival, on quality of life. More recently, if you use validated questionnaires, you see that global quality of life improves after 1 month, and that fatigue and dyspnea go down. In the same paper that I mentioned of Dr. Gratacos, you see that after 6 months is the same. So quality of life for those patients without being problem solved is worst. But this benefit comes with a cost. These costs are complications. You see that you have bacterial colonization with biofilm and infection. You have mucostasis, you have granuloma, and you have migration. It's around 20 to 30%. So you have benefits on survival, you have benefits on quality of life, but you have quite a lot of complications. So probably the future stents, we have the first objective is to avoid complications, mainly biofilm formation and granuloma. See, these are the stents from the last century and also from this century. There are not a lot of differences between them. We can consider they are the first generation of tracheobronchial stents because, in a way, they're just tubular in shape and they only have this expansive radial force. They don't do anything else. So the second generation that has to solve these problems will probably pass from tubular to more complex and from mechanical to pharmacological effect. For that reason, what we need is to improve new manufacturing, basically 3D printing, And from the pharmacological, you have to add some drugs on your stents, so you have to have these drug-eluting stents. These are the complications rates and two possible ways of solving them. You see that for bacterial colonization, probably the drug-active stents are the best solution. This is what you see when you have your stent that has been colonized. You have biofilm, there's mucus plugs, there's coughing, there's infection. And a colleague of yours just presented this like a meta-analysis that collected all the published articles related with infections, and then they just announced this SART, the stent-associated respiratory tract infection. And from these more than 500 patients, they can see that pneumonia is about half of them, bronchial infection a quarter, and then lung abscesses. And for those papers with microbiology, you see that Staphylococcus and Pseudomonas are the more prevalent. In our experience, we have this cohort, and then we just check before and after stenting and follow up all this with a minimum of 52 days. And we could see that for those that were not colonized at the initial moment, they got this colonization up to 70%. And once you have this colonization, it's maintained. So once you have the bacteria inside, it keeps all the time. And the bacteria we could just sample were, again, Staphylococcus and Pseudomonas. It's like bronchiectasis, you know? If you see this from another part of view, you see for those patients that you just treat the main airways and you stent, you know that half of them, those that with stents, will have infections if you compare with those patients without stenting. So when you stent your patient, you know they're going to have some infections. And it's the risk of having is nearly 4 times. So if we are thinking to use drug-eluting stents, we have to know that some concepts. One is stent platform. It can be metallic or polymeric. It can be biodegradable. Then you have the drug carrier, are polymers that dissolve within contact with your mucosa. And then you have a lot of drugs. You can use a lot of drugs in your stents. But to make things easy and just to go and focus to infection, we're going to just talk about silver. We know that silver has different antibacterial effects, high toxicity, wide spectrum of action, reduced bacterial resistance, and it has been already used in endotracheal bronchial tubes in the intensive care with good results. So we were inspired with this and did some first paper in the lab. We were just covering some silicone similar to the one from the stents and then test it. First, we have to activate the silicone and just put a thin layer of silver. So that's how it looks like. And then we tested the dose. You see the black is where is the silver, and those are the ones that the water is clear, there's no infection. So it was the dose we know were killing bacteria. Then we tested it mechanically. So you can see it in flat and also in a stent. You just compress it and it was okay. But that's true that some scratching can be made. You have to think that it's a very thin layer of silver. Then we just check that the release was in the time. So we just check it 3 weeks and it was good after an initial burst of silver. And what is more important, we just check death and alive bacteria. So you see in green are those bacteria that are alive. They're in a normal silicone. And in red are those bacteria that were dead. They were in the plates with silver. So silver avoided and killed bacteria. We also tested what's called hydrophobicity. It is very important because it avoids biofilm formation. If you have a very wide angle, then you are sure that it's going to be a slippery surface, so it's going to be difficult for bacteria to just touch there. Then we just get two normal stents and covered with silver and test it mechanically and put into a rigid scope and then test it and then do the test with animals, with mini pigs, and just stay the stent for 2 weeks. That's how they look at. The normal stent were with some mucus plug with biofilm, and the silver stent was more clean. But what is more important, if you look to the colony-forming units, you see that those with silver were half of it, but it's not a linear graph, it's a logarithmic scale. So having at the half of it, it's 1,000 times, or a lot of less bacteria. If we then try to identify bacteria, you see that in the control stent was mainly Pseudomonas and Klebsiella, around 50%, but for the tested stents, silver stent were really very low, less than 5%. So we have a good effect on the number and the type of bacteria. The silver release was high in the trachea, but not in the rest of the body, and it was similar to these people that have the silver cannula, so no worries about it. So we are really very optimistic with this prototype of stent. The second problem we have to solve with this new second generation of stents is granuloma. We probably can do it with drug-eluting stents. And we have to go to the basics, and we have to know which are the molecules that are in the pathways that are creating a proliferation of cells. Remember this? This is a paper from Cooper. Cooper was one of the surgeons doing transplant, then was the one that were doing the surgery reduction for emphysema. And then he tried to have this endoscopic solution for emphysema, with just having these fenestrations to the bronchi. And they put like a stent there, but they see that they were very rapidly occluded by granuloma. So what they did is in ducts, they just put paclitaxel in these very small stents, and they were able to conclude that if you have these paclitaxel covered stents, you don't have a granuloma. And that's how they look like. Normal stents, the one in the middle is occluded after 1 week, and the other is after 13 weeks. It's not occluded because it has paclitaxel. So you have a drug that can control this granuloma. But there are a lot of challenges when you're using drugs in your stents. You have to know which is the agent, the dose, which is the carrier, more importantly, which is the therapeutic window. You have to know how many days or weeks you're going to have this drug there being delivered. But most importantly, you have to initiate all the regulation, and that's a lot of work and a lot of money. So we'll see if there's enough problems there so the companies can invest in this. The second solution is all this is new manufacturing. With new manufacturing, we're able to control also granuloma, migration, and all this complex tracheobronchial anatomy. If you want to have these 3D printed stents, you have to begin with a CT. Then you have the images, you select those voxels that are around -1,000 units, so it means air, and then you construct your 3D tracheobronchial tree. And then this is the most important thing, you need a software where you can calculate what you're going to arrange. You see there's a stenosis, and then you have to say, okay, I can just do some dilatation or laser and just arrange things, and afterwards you just do what the design of your stent. You send it in a file, and then it's funny. You can just design the stent you want. It's selecting the anatomy and just arranging everything. But then it comes to reality. You have to print it, and you have to send it to a printer, a 3D printer. This is called additive manufacturing. So, I mean, it's done layer by layer, from liquid, solid, or powder. You just melt it with a laser, and then just doing laser by laser, and then you do your whatever you want. But we don't have silicone possibly be done with this system. There's no way to do with silicone. So we have to do more difficult things. That is, you have to print the mold. In this case, we just, you see, you put the orifices where the silicone get into it, and we wanted to have the space to the silicone to be filled. So at the end, you just break it, you break the mold, and you have this. They are not very sexy today, but that's how they look at. We did also another approach. That's the approach we did with the chemists. That's the approach we did with the physicists, with engineers. It's, you can parameterize your stent. It means you can say, okay, I'm going to select 6 variables: diameters, length, and for instance, the different in between rings, or the thickness. You select, and then what you do is you print this more easy mold, and then you pour the silicone on it, and then you break the mold, and then just put in the oven, cook it, and it's ready. We just check in 5 stents, and what you design and what you have is the error were very low, so it's quite nice. So I've presented 2 ways of doing printing. One is the anatomical replication, so you need this more complex way of doing the mold, and the other is this parametric. Probably the hybrid approach, so selecting both, so you can have your region of interest, just do it segment by segment, so it's going to be easier then to join them. We'll see. So there are some challenges. One is you need a good CT, and it's different if you have your axial versus non-axial planes. If you want to have very accurate measurements, you are entering the 3D prescription. So you are the prescribers. You have to design first what you're going to solve in your main airway, and then you have to design your stent. So you're doing a different way of doing medicine you've done until now. And finally, we need these new materials, so we don't have to go to the molding and then after the pouring the silicone. So we'll see if new materials will be there. These are some examples that have been published. This is from last year. There are a complex anatomy in a post-transplant. So you design your stent, then you design your mold, then you do your mold, and then you do your stent step by step. And in this patient, they had this very small dehiscence and these obstructions. So you have first to calculate if you're going to solve it and how you're going to solve it. So then you design your stent and then the implant, and in this case was very successful. Another case published recently is this patient with a very severe tracheobronchial malacia. And then the process is the same. Well, you see the only stent that can be similar, and then the one you can obtain. And when you implant, it goes just there. I mean, nothing is out of sight. And the last cases that have been published, these are the first that have been approved by the FDA. There were 2 patients with Wegener polyangiitis, and this been followed up for 1 year. and they just counted the number of bronchoscopies and the number of stents, and they saw that just with these stents, the patient got very well with very low number of controls and complications. But if we see a little bit further in the future, we see that probably what we need from our stents, apart from not having complications, is try to heal some orphan diseases like scarring, benign fistulas, ossification, and EDAC. It's going to be probably the third generation. So you are active. This is a typical stenosis. Go back to this pathway. So you have to go to the basics and know what is regulated and downregulated. And then you just design your stent and design where you're going to add your drug. In this case, this is the drug-eluting area. But we can imagine that like this is used in ulcers. You can use different layers of drugs. So you have a multi-drug option. What about ossification? This is difficult sometimes cases that are impossible to solve. Well, again, we're trying to stop scarring. We're trying to stop ossification. It's just a diagram that's saying that, well, there are cells, there are contacts, so probably sometimes someone will be able to solve and just say, okay, that's a crucial point, you can stop. And what about fistulas? We're trying to cure by stopping processes. This is the other way around. We're trying to cure by trying to have growing tissue. You can use these stromal multipotential stem cells from fat. It has been used in some other issues. So you can use, why not, in fistula, because you need to fill the hole with normal tissue. It has been used in some very small cases. In this case, we're using also argon plasmas, so there's also an added tool there. But the thing is, they could solve by injecting this fat from the patient inside the fistula. And if we go a little bit further, probably you can finally print the cells. So you can put your scaffold with the cells and then add where you, like a patch, and add it where you want. So probably fistulas should be solved soon. The fourth situation we could maybe endoscopically treat is excessive dynamic airway collapse. And we have to just think about these bulking agents that are used just to make thicker things, thicker mucosa. And this is this pyrolytic carbon. It's already being used for urinary tract incontinence. So just put it under the mucosa, they just add it and it stay there and forever, no problem. So if we think with these biodegradable stents, first is when at the top is when you implant, and after some weeks is how they they finish, so they degrade. But what about adding some spikes that have this pyrolytic carbon that get into the mucosa and stay there? So you can use your stent as a carrier of other agents, like in this case, the carbon spikes. And in this third generation, so we're not solving problems, but we're trying to heal these orphan diseases. Why not being smart? We know that we can have signals from stents that are inside. This is a biliary stent that has this magnetoelastic sensor inside. Then you see there's a peak, and put this like those two magnets, and then you see that you can have a signal from this sensor as far as 7.5 centimeters. So you can have some kind of connection with your stent inside the body. As always, cardiologists go very fast, and they have already put first 2 sensors in this metallic stent, and one antenna. So they can just know when the stent is collapsed, and then they can have some kind of communication with the outside. So the third generation, you can have this more complex and those more pharmaceutical drug-eluting stents, but the stents will probably have these multi-sensors as an antennas. So you have sensor for position. Also for colonization, you can have different molecules that go around, and inflammation, why not? And then you have these ways of communication between one and the other. So in the end, the patient can be happy from using this telemedicine. So it's going to be third generation. In summary, I would say that this second generation stents would, first of all, reduce complication. That's the first and the main important thing, maybe less than 5, less than 10%. And why not heal these orphan diseases? And in the third generation, it should be this endoscopic orphan diseases treatment, and also this telemedicine control. So at the end, we have the future in front of us. We only have is to connect the right dots. And just with saying this, thank you very much and Merry Christmas.
Thank you very much, Tony. It was a fantastic lecture. Liberate our imagination.